Good morning, good evening. Welcome to today's Fintech for Health event. I am Chang Liu from Access Health International. It is a great pleasure to be the moderator today and to co-host the event with our partner, MetLife Foundation. Today, we have with us experts from both finance and health sector across the region to discuss a very important topic, how Fintech can improve access to healthcare in Asia. Each year, 1/3 of all new cases of poverty in Southeast Asia are due to healthcare costs. While universal health coverage is the ideal state of paying for and guaranteeing care, it is not feasible for many countries in the short term. Financial services has been playing an increasingly bigger role in addressing out-of-pocket costs through innovative business models and new technologies that eliminate inefficiencies and improve access to high-quality healthcare. Since Fintech for Health was first conceptualized in 2017, Access Health International has been bringing together the right people to address these issues. With the support from MetLife Foundation, we have developed frameworks, conducted extensive research, dialogued with large and small fintech and healthcare players in 6 countries, identified multiple problem statements through conversations with patients and healthcare assistants, and brokered countless conversations around solutions to address the needs of these vulnerable populations. Today's webinar marks the launch of our first Fintech for Health white paper, Breaking the Health Poverty Trap, How Fintech Can Improve Access to Healthcare in Asia. This publication acts as the guiding framework for current and future partnerships formed under this program. The problem statements, case studies, and innovative solutions in this paper are derived from our research and initial lessons and are applicable globally. So first, please allow me to introduce our distinguished keynote speaker, Evelyn Stark, Financial Health Strategy Lead of MetLife Foundation, to give your keynote. Please, Evelyn.
Thank you very much, and good evening or good morning or good afternoon to everybody on this call. I'd like to begin by, of course, thanking Access Health for giving MetLife Foundation an opportunity to comment. I, of course, like all of you, would have preferred that we were able to meet in person, but by now we are very much used to being connected virtually. I think it's fair to say that health, or more accurately illness, has been on all of our minds as the pandemic has hit each one of our countries, our cities, or our families. And of course, we know that the poor will face greater negative impacts from COVID, as is true from all diseases. A recent New York Times article caught my attention as I was thinking about this meeting. And the headline of the article was, "Rich people don't just live longer, they get more healthy years." The article summarized a recent study on more than 25,000 people in the US and the UK, which said that wealthy men and women don't only live longer, they enjoy more healthy years after the age of 50 than the poorest individuals in those same countries. So wealthy men tended to live 31 disability-free years after the age of 50, which is 8 or 9 years more than poor men. At a global scale, as we know, the WHO estimates that at least 100 million people are pushed into poverty every year because of healthcare expenditures. And the pandemic is only erasing years of progress and exacerbating this push into poverty. The World Bank estimated that before this recent wave of pandemic hotspots, that an additional 88 to 115 million people are likely to enter the ranks of the extreme poor in 2021. So there have been many efforts, as all of you know, to decrease the cost of healthcare for low-income people. National health schemes, free clinics, reduced price medicines offered either by the public, the private sector, or nonprofit. And for a variety of reasons, these efforts have not succeeded in helping millions. They've succeeded in small cases, but not in helping millions of people access and use needed care. And of course, in the separate financial services sector, there have been some products designed specifically to cover healthcare costs for low-income people: health savings accounts, hospital indemnity, loans or credit, and of course, health insurance. But also for very many reasons that all of you could go on about, these products have not successfully reached the millions. These efforts have largely been done separately, and there have been few efforts to bring together the financial services sector and the healthcare sector, which is what's so interesting about this program and this meeting today. So technology really offers the opportunity to bridge that divide, making it possible for healthcare, governments, financial sector providers to collaborate, co-create, and scale new and innovative solutions to address the ever-rising costs of care and the burden on particularly low-income communities. And technology offers the potential for much faster iteration of ideas across a much wider physical and sectoral landscape. Again, even though we're not in person, we are in a much wider physical landscape today than we would have been even a year ago. So Access Health International and MetLife Foundation have co-designed this first of its kind regional platform to bring together leading finance and healthcare providers, as well as the newer innovators and startups, with this purpose of finding solutions that increase low to moderate income people's ability to afford and access healthcare services. The platform objectives are threefold: test and scale, so that we can test and scale projects that do help people pay for and afford the care they need, using a combination of digitally enabled healthcare solutions and financial solutions. We're also here to promote cross-sectoral innovation in healthcare access and affordability, and to conduct research on best practices, blending finance and healthcare innovations, and to share that research widely. The white paper that Sejal will soon share, I hope, will spur further dialogue and action, whether that's locally, regionally, or internationally, so that we can focus on the needs and challenges and opportunities for healthcare providers, governments, technology providers, and financial services providers as well. The goal of Fintech for Health is to forge and support partnerships that can build these solutions, enable low to moderate income people to use high quality healthcare services in an affordable and timely manner without jeopardizing their family's financial health. MetLife Foundation is very pleased to partner with Access Health on the Fintech for Health platform, and we look forward to working with all of you. So I thank you, and I'm looking forward to the panel and the rest of this session.
Thank you, Evelyn, for your wonderful remarks. And I think you really addressed the opportunity and great needs for the cross-sector innovation and collaboration. And that's exactly really this program is about. And I think next, let's welcome our next keynote speaker, Dr. William Hazelton, Chair and President of Access Health International, for the white paper announcement. Please, Bill.
Thank you, and thank you, Chung, and thank you for the team. And Evelyn, thank you very much for your kind remarks. I'd just like to begin by thanking MetLife for their interest in this topic and for the close collaboration that we've had over the months and in the preparation of this white paper. It's a very exciting moment for us. It's in some sense the fruit of a program that Access Health has been involved in some time. And I'd like to recognize Adrian Mendenhall, who's been a key driver of this, of course, Chang Lu, and Sejal, who's the head of our Southeast Asia programs based in Singapore. This has been a wonderful collaboration, and I think it's just the first in many steps along a long road to making sure that people in Asia have access to high quality healthcare, either through the government or through the private sector. And it's very important for the health of these individuals and for the health of the country and indeed for the world. I think this pandemic has highlighted the importance of health. Everybody knew how important it is, but now we really understand in a way that I think we didn't before, the fundamental saying that health means wealth. There's such a tight junction between the health of the individual, the health of the population, the wealth of the individual, and the wealth of the nation. The pandemic has really laid bare the growing chasm between the relatively few who can access and afford high quality healthcare and the many who cannot. As you know, in Asia, this is especially a challenge. Each year, it's reported that 65 million people fall into extreme poverty because of the cost of healthcare. That just isn't reasonable. It's not tolerable. The world is working to lift people out of poverty and into the middle class. And this pandemic and other health issues are just pushing hard against that. So nobody should be forced to choose between caring for their children, buying food, and paying for healthcare. And when I created Access Health now over 15 years ago, I wanted to help level the playing field and to find a way to bring high quality, affordable healthcare to all people, no matter where they live, no matter how much they earned. From the beginning, we focused on identifying the most promising innovations and best examples of care, understanding how they work, and figuring out ways to help others replicate the success. I'm very pleased to be with you today to discuss the next wave of healthcare innovation. Fintech for health, Fintech solutions. Fintech has penetrated so many aspects of our life. It's amazing it's taken so long to penetrate what is 20 to 30% of the GDP of most countries. Imagine one of the most powerful technologies not systematically applied to an enormous sector of our financial world. It's where digital services help people pay for and access care. It can help fill the gap between what governments are willing to pay for when it comes to health and what those in need are able to afford. I'm excited by the work that our teams in Singapore, India, and China are doing on FinTech for health. And I look forward to the panel discussion and the circulation and feedback from the meeting today and from our white paper. So congratulations to everyone who's been involved. A special shout out for our friends at MetLife who've been with us through this program, and enjoy the program that we have prepared for you. Thank you very much. Chang or Adrian, I hand it back to you, or whoever's taking it from here.
Thank you, Bill, for the wonderful remark and announcement. I think after today's launching, we'll print out the cover of the white paper for your background. So I think next, let's welcome the co-author and one of the real leader for the FinTech Health program, Sejal Mistry, the regional director of Southeast Asia Access Health International, to share the key findings of the white paper. Please, Sejal.
Wonderful. Thank you, Chang. Ivan, if you don't mind putting up my slides. Okay. It's a pleasure. It's a pleasure to be here today. We've started this program about 1.5 years ago, and we've been learning a lot in this process. And today we're going to tell you why and how FinTech for Health can play an important role in bringing healthcare access to millions of people in Asia. In the last 2 years, Access Health had focused on this concept of FinTech for Health, and that is the way we describe it is the use of finance technologies and digital platforms to solve for finance challenges that people face in accessing healthcare services. When we started this program, we were often asked, what does FinTech have to do with health? And why are we, a healthcare nonprofit, talking about savings, lending, alternative credit scoring, and basic banking? I have a next slide. Sorry, and next slide, sorry. So the answer to that really is encapsulated by this question and by this figure. As Bill has pointed out, there is this inextricable link for much of the world between access to finances and access to healthcare. We know that a person with ill health is often not able to work and maintain their productivity. This results in low levels of income, savings, investments, and ultimately a lower standard of living. One's ability to work and thereby generate wealth is undermined by poor health. And the money that is needed to pay for healthcare is often out of reach. Low-income people cannot easily save, borrow, or raise funds to cover their treatment for illness. Thus, a cycle of poverty and poor health continue. Next slide. There are 5 financing challenges that we identified for our research in Asia that are impeding access to healthcare and where we think FinTech can help. The first is that healthcare costs are expensive. In the Asia Pacific region, the upward trend in healthcare costs is quite alarming, with a regional average of about 8.6% medical inflation, and that's 3 times the global inflation rate of goods and services. That out-of-pocket payments, the payments that an individual makes at the time of healthcare services, is the worst form of healthcare financing. In this region, out-of-pocket payments are high, and in places like India, it's as high as 62% of total healthcare expenditures. In Bangladesh, it's 74%. Third, healthcare costs go beyond the cost. One such example is the cost incurred when traveling to a healthcare facility to receive services. This is particularly evident in Asia, where 66% of the population in South Asia live in rural settings, and in East Asia and the Pacific, it's about 41%. Fourth, healthcare costs are unpredictable. People often don't know when and how much money they will need for healthcare. Have the savings or the liquidity to absorb the shock of healthcare costs incurred from a bad road traffic accident or a cancer diagnosis. And finally, healthcare costs are often not linked to healthcare outcomes. Outcomes are not guaranteed by hospitals or doctors. At the level of the individual patient, this disconnect between costs and outcomes puts tremendous pressure on a household and may not result in better health. For those who face severe and life-threatening illnesses, this is a gamble that could result in death or bankruptcy and generational whole family poverty. Next slide. The Fintech for Health Innovation platform has been a starting point for addressing the financial challenges a person faces through life in paying for and accessing care. By identifying specific points where individuals are most likely to pay out of pocket and are vulnerable to high costs, we hone in on where and when Fintech solutions may have a role to play across the life cycle. Even when there is a system of universal health coverage, there are key services that have to be paid out of pocket. For example, the treatment for some types of cancer, diabetes, and other non-communicable diseases. These are often not covered by UHC, and these expenses can be enormous. Next slide. Let's look at an illustrative case of a young woman here, Rashida. Rashida is a 23-year-old Bangladeshi woman living outside of Dhaka with her husband, young son, and her elderly mother-in-law. She cleans houses, works in 3 separate homes. She's now pregnant with her 2nd child. She needs to visit the hospital for at least 4 prenatal visits to ensure her well-being and that of her baby. While her husband works as a laborer, she also needs to work to help support the income of support her family. There is financial support from the government for maternal care for all pregnant women, but neither Rashida nor her family know about it or can access it easily. And when you look at her patient journey on the slide here, you see that every point of that journey is accompanied by a financial journey where she and her household has to make decisions. Do they have enough money to support her health and well-being during her pregnancy? Do they have money for transport to go to the district center? When she has her baby, if there's any complications, she might not be able to work anymore. And these are very important questions that often get hidden when we talk about healthcare. Next slide. Now we will come back to how Fintech for Health can help Rashida, but I do want to talk about Fintech for Health in the broader context of the societies we live in today, and why this can be such a powerful solution for healthcare financing challenges. Next slide. Fintech for Health is enabled by 3 global trends we're seeing today. First is digital transformation. Digital transformation is driving healthcare transformation. The use of digital technology has redefined the way we live, interact, and do businesses on a global scale. As of 2019, the World Bank estimated that 57% of the world had access to the internet, 67% had access to a mobile phone, and 47% had access to some form of broadband connection. We shop online, find jobs online, learn online, find partners online, and now we are also seeking healthcare online. The second trend I want to talk about is financial inclusion. Fintech is rapidly increasing access of financial and other digital services among the low to moderate income segments. Through the premise of financial inclusion, Fintech has and continues to make remarkable contributions towards access and usage of financial services of low and middle income people. In just the past 6 years, 1.2 billion people worldwide have gained access to bank and mobile money accounts due to financial technology. And lastly, a trend that is very important to us in healthcare and to access health is the principle of universal health coverage, that all people have access to health services they need without suffering financial hardship. In 2015, world leaders committed to the goal of universal health coverage in the landmark Sustainable Development Goals meeting of the United Nations. UHC is an explicit attempt to de-link wealth from health and break the health poverty trap. We believe that FinTech for Health can be additive and complementary to the goals of universal health coverage, helping to fill in gaps and address the persistent current health challenges as countries progress towards full population coverage of quality and affordable healthcare. So how can FinTech for Health work? We have created a framework that integrates FinTech services, healthcare services, and essential enabling technologies. And we're using this framework to solve between FinTech partners and healthcare providers. Using enabling technologies, healthcare and financing products become easier to deploy and scale, particularly in reaching underserved populations. We identified 4 main digital technologies that enable FinTech for Health models: information, data analytics, e-wallets, and digital ID. The entire solution and underlying digital capabilities rest upon a digital platform, or increasingly a super app. These are the same technologies that are changing all services and markets. For example, e-commerce, transportation, ride sharing. We're just using those same technologies and now bringing it to the healthcare sector. Now, when you look up top of this framework, we have common financial services that have existed for a long time: savings, insurance, donations, and loans. But now we have the digital version: digital savings, crowdfunding, insurtech, and digital loans. The advantages are all these services are accessible to more people. They're more practical and often more economical. In the middle layer we see here with the 2 large circles are the online and offline medical services that we can integrate. And in a COVID-19 era, that digital access to healthcare has become so important. By bundling financial services with healthcare on digital platforms, we can help to drive convenient and affordable access that is customized to a person's healthcare journey. Now, I just want to note that we developed and refined this framework through successive iterations and discussions with FinTech and healthcare providers to attempt to provide a common understanding of the challenges to be solved for. This framework is not exclusive, and we're refining our model as we go along, as we get more experience and input. We know, for example, that there's a universe of FinTech for Health use cases for health systems, and is an area we want to really get into. And we would welcome your input and ideas in helping us shape our solutioning for FinTech for Health. Now let's go back to the case of Rashida. Next slide. Now, to take a FinTech for Health approach for Rashida, we can see that in this instance, the key component that we can now help bring to Rashida is the financing for maternal health package from the government, which she was not able to access easily before and she did not know about. The first thing that will help Rashida is the digitization of payments. Having a digital wallet through her smartphone, Rashida can now accept and have immediate access to money. In the same platform, she can receive notifications. For example, messages that remind her of her prenatal visits and gives her health information about her pregnancy. Rashida decides then to go to a clinic nearby in her own neighborhood. Her clinic has a healthcare worker who can provide basic healthcare services, but for a full checkup, she would need to consult an obstetric specialist. This she is able to access at the local clinic through a teleconsultation. In this example, Rashida would be able to pay for any fees as needed through her digital wallet. And we know that in many cases in countries, even people at the lowest income levels are going to private sector care. They will pay for the care that they can afford, and they will need money for that. And finally, with this FinTech for Health approach, when Rashida gives birth, she would have, through this approach, had her 4 antenatal visits, information about her care and her baby's care postpartum, and would have received high quality healthcare services. Importantly, we're going to hear from our panelists about real case studies of the use of FinTech to drive access to healthcare services. Sorry, next slide, please, Ivan. So we're going to hear from our panelists about real case studies to drive access to healthcare services, information, and financing. But before that, I want to leave with 3 key takeaways that we've learned from this program. First of all, is that health financing must be people-centered. Patients in low and middle income countries in the Asia Pacific region on average pay for half of their healthcare expenses out of pocket. Yet healthcare financing is often discussed and analyzed at the health systems level, not at the individual level. To create effective and realistic financial solutions, we need first to understand patients' financial decision-making regarding accessing healthcare. Secondly, the best solutions will be bundled, integrated, and comprehensive. To be patient-centered, solutions providers must consider the totality of patients' needs and preferences solving at different points of the patient journey, and partnering with other solutions providers when necessary. And finally, to reiterate the point that Evelyn had made earlier, the finance and healthcare sectors must come together. The development goals of universal health coverage, the goals of financial inclusion are essentially the same. We are all helping people to live the best possible lives that they can. For healthcare, we need the finance and healthcare sector at the same table, so our efforts are synergistic, not siloed. Next slide. So with that, I'm going to conclude my remarks. Thank you very much. You can learn more from our paper at the QR code here. And with that, I will turn it back to Chang. Thank you.
Thank you, Sejal, for sharing with us the key takeaways on why FinTech for Health is urgently needed to address the healthcare financing challenges of low and moderate income populations in Asia. So next, let's welcome the co-author of the white paper, Adrian Mendenhall, along with experts and FinTech for Health partners to discuss the insights we gained so far and the next steps in expanding the partnerships. Adrian, I'll hand over to you to welcome the panelists.
Thank you, and thank you everyone for joining us today. This, as MetLife Foundation knows, is that this white paper has been a long time in development. And the reason for that is because we are continually, like Sejal mentioned, adding more information, because not only are we publishing a paper and hosting sessions like this where we bring people together, but we are working with partners to create these types of projects on the ground in 6 countries, in India, Nepal, Bangladesh, Vietnam, Malaysia, and China. And so as we go about this, we learn a lot through the process, and including not only since we launched this program in late 2019, but of course also with COVID-19. So just reiterating a couple of the points that Sejal had made is, I would say about 14, 15 months ago, we were still talking about, when we talked about FinTech for Health, it was about innovative financing. And now it really is this complete perspective of how is FinTech one aspect of a really digitally enabled ecosystem-based approach to patient-centered care. So we can take patient-centered care and move it out of, sometimes it can be treated as almost a cliche or an ambition, but really saying, if we put patients at the center, how can we use digital health services? How can we use FinTech? And how can we deliver information digitally as well to provide the care, the information, and the financing that patients need when they need it? So thank you to all of our panelists today who are going to be able to add a lot more nuance to everything that I've just said, and give us some of those very practical examples on the ground where we're seeing both these models being rolled out, but also the opportunities that we see, both with the broader challenges around health systems, but also some of the particular challenges that we're seeing with COVID-19 as well. So, first, Monique Delphing, I'm going to absolutely pronounce your last name incorrectly, so I am not going to do that. My maiden name is Dutch, and I know I still can't pronounce Dutch last names correctly, but the CEO of Pharm Access Group. And I first heard you speak over a year ago at the Prince Mahidal Award Conference about CarePay, and so very happy to have you here today to talk about the work that Pharm Access is doing and really leading globally in this area of applying digital financial services to healthcare. So if you'd like to just introduce Pharm Access and tell us a bit about CarePay and the MTBA wallet as well.
Thank you, Adrienne. And it's so strange because these are these moments when you realize how much has changed over the past year, because I vividly remember that we met at the conference and we were just being confronted early days with the COVID pandemic. And congratulations to see how busy and how productive you've been despite all of the lockdowns in advancing so much and producing this white paper. So congratulations, Access Health International, on this great achievement. Let me start by that. And indeed, we as Pharm Access, maybe just as a word of introduction, we are an NGO that basically was started during the previous pandemic, the HIV/AIDS pandemic. in which particularly hits Africa very hard, and at the moment where treatment and medication was widely available throughout the Western and the developed part of the world. In Africa, people were dying by the millions, and treatment was not being done because of technical reasons and financial reasons and political reasons. So that basically was the birth of our organization. And since then, it's been in our DNA to really look at new developments, to see how we can address certain healthcare issues. And we do this in a multi-pronged approach, where we really very much always start from the financing side. So I think this is very much where we have in common by saying, you know, you can look at the individual supply mechanisms, but basically the problem is so complex because of a vicious cycle in terms of how healthcare is being financed. And therefore, we always take a number of approaches where there's two starting points. One is to include the private sector in everything that we do. Because of these financing challenges, you do see that there is, apart from, of course, it being a public good, but in countries where the healthcare spending is just below what is needed, significantly below what is needed, a private sector emerges. So, and that needs to be complemented and integrated. And then secondly, especially the past, well, 5 to 10 years, we have looked as much as possible how we could leverage technology, and the fact that we were in a big digital revolution globally, and how we could benefit from taking some of those learnings to address healthcare. So basically what we do is three things. How can we organize demand? So how can we better organize the financing? We always like to use the phrase uniting fragmentation. Basically reduce the out-of-pockets and see how we can move from post payment to prepayment, because that is one of the fundamental challenges. Then secondly, also, of course, looking at the quality of care and how to make it more transparent. So how to benchmark and introduce standards so that governments, insurers, and investors, but not last but not least, also the patients, very much can understand, you know, the quality of care being provided, and for the providers having a pathway to how to improve and understand where they stand. And then thirdly, it's very much about financing. Because of this enormous private sector that could not access financing to expand services, to improve quality, to buy equipment, to finance their supply chain, we do investments there. And then basically overarching of all of that is the technology, where we look at innovative care models made possible by technology. And we are now trying more and more to work towards more of outcome-based models by combining the financing with care bundles to patient journeys. Well, let me pause here, but these are just some of the things that we do. We work in Africa. We are a Dutch African NGO. We have our head office in Amsterdam, but we have very strong country offices in Ghana, Nigeria, Kenya, and Tanzania.
Thank you very much. You know, we've been really fortunate to host CarePay a few times in webinars over the last year, and I feel like I always have 20 questions every time I hear more. Moving on to our next panelist, Shamar Karkal, who is the CEO of Swasti Health Catalyst in India. Thank you for joining us today. Can you please give us an introduction of Swasti?
Thank you, Adrian, and I hope you can hear me clearly. Good evening, everyone. It's evening here in India, so and it's been fascinating to listen to everyone. I feel actually at home, because these are topics that we've been discussing and working on for many years now. Swasti is a nonprofit. We're a global organization working in multiple countries as technical experts. A large part of our work in community tends to be in India. And like Monique, we got started about 17 years ago, actually 19, because we were founded in 2002. And it was during, you know, the HIV pandemic. So I think we have some common lessons in terms of how we work with people and people-centered care there. And over the last 10 years, I think we've moved to looking at comprehensive integrated healthcare for those who are often left at the margins of society. While we've always focused on prevention, I think we strongly started looking at financing and looking at the intersects of why people get left behind, why they have ill health, and why we aren't able to focus on prevention as much. And I think that's really what, the three key takeaways, and we've really moved in that direction over the last 10 years, is people-centered care. How do we make it integrated, comprehensive, and how do we bring health and finance together? That's the bulk of the work that we do in community today in India. Our largest flagship program is called Invest for Wellness. And it's simply because the community invests and the ecosystem invests. And we believe that is going to be essential, both from a prevention perspective, as well as subsequently a treatment perspective. And we work across multiple populations, and our work spans both urban, rural. We also work with the private sector, so we work with informal workers as well as the formal workforces in the factories. We do a wide variety of work as technical experts. We work in public health, of course, and that's how we know actually Access Health and many of the other organizations that we partner with. We've specifically focused on COVID action as well, because we think building resilience in the system, specifically around healthcare, of course, but then I think system innovation, and there's been a huge opportunity over the last year, and I think going forward for a few years, to actually fundamentally redefine how systems work, both for finance and for health, especially for the poor. Thank you for this opportunity, and really look forward to the discussions.
Thank you, Shama. And our next panelist is Anir Chowdhury, who is the policy advisor at A2I, which I usually like to describe as essentially the digital innovation arm of the Bangladesh government. Anir, can you please introduce yourself and A2I, and especially some of the work that you're doing around digital financial services and health?
Thank you, Adrian, and thank you for inviting me to this very distinguished panel. I'm probably the newest kid on the block of Fintech for Health, but I seem to be sitting on the nexus for what is to come potentially. So I'll talk from that perspective. So A2I is the Bangladesh government's flagship digital transformation program, as you mentioned. It was born at the Prime Minister's office about 14 years ago, tied to the Digital Bangladesh agenda of the government. It functions from the Cabinet Office now and the ICT Ministry. So it basically ties in the political, the bureaucratic, and the technological hubs of the entire government. In the last 14 years, we've actually done a number of things, one of which is developing a set of what we call digital centers across the entire country, about 6,000 of them, which is the bridge between the analog citizens and the digital service delivery. So it actually, these centers deliver nearly 280 types of services, public and private. So these are very unique public-private partnership enterprises sitting in government offices, but delivering services at a small cost to citizens, run by entrepreneurs, micro-entrepreneurs. About 4 years ago, we started working on financial inclusion, digitizing the entire social safety net program of the government, which is 14% of the national budget. So it's quite large. And by the end of this year, we'll probably do most of the digitization. So it's centralized MIS systems, connecting with agent banks across the entire country. So these 6,000 centers actually deliver cash to the end beneficiaries, but the entire transaction is digital. So we also use the mobile financial services, which is a rising trend in Bangladesh, as you all know, which will probably play a major role in Fintech for Health. We have been very active in DFS, the Digital Financial Services Policy Reform. The eKYC mechanism that we introduced in 2019 was used heavily to serve the new poor during the COVID period. So about 5 million new poor households were served using this eKYC mechanism with the national ID. So that may be another building block for Fintech for Health. On the health front, we've been very active to develop a health ID with a civil registration and vital statistics, CRVS. So we've been working with the Ministry of Health and cabinet to develop that across the entire government, linked with birth registration, linked with national ID and all of that. During COVID, we got closer to the Ministry of Health and the DG Health Services to develop a syndromic surveillance platform where citizens could self-report so that we could track where the disease was progressing even before RT-PCR tests were set up in the country across the board. We developed a number of telemedicine services, one focused on COVID patients, one focused on pregnant women and lactating mothers. And in general, there is a Uber-like telemedicine service where doctors volunteer their service. Thousands of doctors actually come there. And we have a data analytics platform that we developed, which bring in health data, mobility data, and socioeconomic indicators to understand the impact of COVID, not only on health issues, but also on social economic factors. So in summary, I would say that we have not really done any FinTech for health initiatives yet, but we have a lot of building blocks which have been very crucial in moving the needle for all the discussion that Sejal and Adrian you've talked about. I think we want to do the innovation at scale. I mean, that's what A2I is known for. Our innovations don't sit in labs as prototypes. They actually, because of the administrative structure that we have formed in the last 14 years within the government, it's actually taken to scale very, very quickly. So I'll stop there, maybe add more later on. Thank you.
Thank you. And you've given, I think, so many examples that touch on different points within the framework, from digital ID to the data analytics. And there's one phrase that you said in particular that really resonated, is being that bridge to analog. And a lot of times when we talk about digital, I think people have the notion that it's either all digital or all analog, and saying, you know, the right approach is probably a combination of the two. And how can technology just be that bridge? So thank you. We have many questions ahead.
Unless we all become robots, we have to bridge the analog to digital. Right?
Yes. And our next speaker is Dr. Shizhen Mo, who is the Deputy President in the Chinese Academy of Financial Inclusion. Dr. Mo, can you please give an introduction of yourself and the center?
Yes. First, thanks for inviting me to join these discussions. And I'm come from the CAFE. We call it CAFE. It's the Academies for Financial Inclusions. We are quite new organized because it just starts from 6 years ago in the universities. And we are set up to promote financial inclusion in China. So the way we do is to produce or recommend some policy suggestions to the government based on our research. And we also provide capacity building for the government and also for the supply side and demand side. We have basically we do three things. One thing is that conducting research in these 6 years. We already conducting about 65 research projects. And then we also, the other things, we have platforms, we call the forums every year, which brings together the governments and the supply side and also some experts from overseas to exchange their opinions on financial inclusion. And the third thing we do is to provide capacity building. That's training the government officers and also training the people from the banks and also some people from also for the consumer officials to help them to improve their capacities so that they can involve in financial inclusions. So in these years, we also working on the the impacts that conducting a research on the impacts of COVID-19, and then last year we review documents that give to the central governments, and they accept our suggestions to provide subsidy or provide health to the SMEs and some individuals. So in general, we are working for focus on the inside China now. So also we have we try to connect to the other countries in the 2019. So we also have forums with the African countries to exchange the opinions of this, and we also want to continue this, but it interrupted by the COVID-19. So we hope that in future, so we can working with other people from other countries to promote financial inclusions. So I think I stop here, and thank you.
Thank you. And I think that, sitting here in Southeast Asia, we do hear a lot of, I would say, companies that are inspired by the strides that have been made in China around financial inclusion, and how digital technology has been instrumental in that. We hear this quite a bit. So we are always, wanting to learn from what has been accomplished in China, and how these models have really been used as a baseline for innovation, including in the healthcare sector as well. Our last but definitely not least panelist is Arun Dutta, who's the Senior Health Specialist with Asian Development Bank, focusing on health financing. And can you please introduce yourself and your work as well, and especially your interest in this area of FinTech for health?
Thanks so much, Adrian. It makes sense for me to go last. I mean, as a development bank, we like to stay in the background. We're here to support. We're here to provide financing and technical support when needed. But really, we're enabling as much as possible these kind of innovations. So where I sit, in the hub at ADB, supporting all our regional departments, I'm seeing a big trend in a push for digitization across our operations. I think our developing member countries are requesting more and more support that includes a component of digitization, whether that's about e-governance, moving more and more government services onto the web, into the cloud, or whether that's supporting our government partners in including financial technology, like I think what we'll be talking about today, in payment services for providers, or in improving the innovation capacity of their national insurance systems. So I think as ADB, we are excited to see this trend. We are totally behind it. I think we'll be putting resources into this as much as possible, working with our technical partners and our member countries. You can see this push in our strategy 2030, which has a strong digitization component. That's our vision for the next decade plus in the Asia Pacific region. And I think we're very happy that our region is sort of leading from the front. I mean, we have countries, I think we have examples on this panel that are showing how you can really create a people-centered, patient-centered as well, digital economy, a digital ecosystem that really tries to create the best outcomes, both for the payers as well as for the patients. So I'll be very happy to speak about this. It's a personal interest of mine, certainly even before I came to the ADB. A lot of work in this space, both in Asia and Africa. So very excited to be on this panel. Thanks, Adrian.
Thank you very much. And so, starting off with some of our questions, I'm going to start with Monique. And this is because, again, I think in the conversations that we've had over the last year, the MTBA model is probably the most well-known globally, or one of the most well-known, which really shows the innovation from Farm Access early on. So what was it that, how did Farm Access decide that you were going to create this model and you were going to really invest in this integration between digital financial services and health?
Yeah, thank you, Adrienne. Well, I mean, when you look back, it's always easier to put into perspective what your thinking was then. But basically, it was a number of big trends that we saw. First of all, the enormous breakthrough and the impact of M-Pesa. M-Pesa is the mobile money that was started by Safaricom already around 2005, 6, 7. And that was totally replacing any cash transfer. And the interesting thing is that it showed that people were willing to prepay and were trusting that. And it was direct. It was enabling many people to access financial services that could not before. Then at the same time, of course, we were realizing that slowly we were all getting a supercomputer in our hands, right? And even if the mobile money was still being run on feature phones, we could see that the entrance of smartphones was also coming, but also looking at indeed all of those patient individual-centered services that were emerging, like Booking.com, Airbnb, the Ubers, etc. And then we started thinking, so if that can be done in that sector, how can that be used to the healthcare sector, where you have a principal financing problem, where you have different types of payers for services. And normally you have an e-commerce where you pay and you negotiate a good price, but here sometimes the payer is not the same as the person that's actually using the services. We had been doing a lot of work around health insurance, and we saw that basically low-cost packages were just very difficult to make into a good business case because of the high cost administration, the distribution problem, low transparency, the claims processing. On an average $60 or $100 package, you were spending so much on admin. Now, looking at mobile and digital transformation, of course, there's the opportunity of doing everything at almost zero marginal cost. Everybody is connected through a mobile phone. So that got us thinking. And then we started to working around the model of a mobile wallet. Saying that, in fact, if we could just on top of M-Pesa put a mobile wallet where, people could virtually own their healthcare benefits, not per se being its actual cash, but also just the title of a something that you are entitled to. And that could be an insurance, it could be voucher, etc. So that led to the birth of what we call M-Tiba, which is a healthcare payment platform. That's how I best like to describe it, which connects the payers, which can be many, and the individuals and the healthcare providers, and basically do a whole healthcare payment settlement. Well, if you come to think of that, because, and I think that was very nice also in the presentation that was given earlier, the patient journey that everybody goes through is the same everywhere. And it starts with the identification of a person and then going through the whole journey, including all of those payments. So that is basically what M-Tiba facilitates. And when we launched it in a partnership with Safaricom at the time, we realized that this was going to be potentially much bigger than that we as a not-for-profit could do. So we spun it out of Farm Access, and it was founded as CarePay, which you referred to indeed. And CarePay is a social enterprise, which now resides outside of Farm Access, and has also started working in Nigeria and is looking for other expansions. And we work with them to see how we can help social health insurance platforms evolve. And they themselves are also looking at how to move more towards insurtech models that can open up the market also to provide healthcare insurance packages for the missing middle, as we always like to call them, of many people that that are in the informal sector and that could procure a model. That's how we got into that, starting already in 2014, and now having a few million people connected. And we are trying in different types of partnerships to prove how the model can work in what circumstances.
Thank you. And there's one thing that, you know, I've heard you speak about before, and I just want to touch on this while we're talking about technology as this integration, is you've said how, you know, the MTIBA wallet connects payers, providers, and the patients, but also how it can connect the public and private sectors as well. Because you talked early on about, you know, farm access, really believing that the private sector has a strong role to play as well. How has something that, you know, admittedly, when we started talking about fintech for health, people would kind of smirk and they go, you mean like digital payments? You're just going to pay for something with e-payments, and make it sound like it's just this very simple thing. That's not innovative. But then by having just that, what sounds simple, but being this baseline technology, you know, some of the things, and I'm just going to ask you to touch on these, where, you know, by having this wallet, you can have different payers pay for a patient, and it acts as that integrated between public and private sectors. Or with some of the, I think when we met last year as well, you had talked about how it's been able to enable loans for clinics as well. So something that sounds simple. So if you could just elaborate on that a little bit as well.
Yes, sure. So what basically the payment platform does is that when you have a scheme, depending on how it's structured, it's basically settling and registering from this, basically this digital fingerprint, the ID of the individual to the services, and making sure that the provider get paid for the services that were rendered. Right. So the fact is that you would still need, of course, a strategic purchaser, and that can be in many forms, right? So it can be in the government, but it can be also a social health insurance fund. So as an example, we are working together with the Kisumu County, which is a region in Kenya, which have launched their own scheme, which is linked to the National Health Insurance fund. And with MTIBA, we help them identify and enroll and register all the individuals. And when they access the clinic, they identify themselves through this individual code. So we can actually start tracking that they have indeed accessed services. And then through that mechanism, file all the claims to the NHIF and make sure that the payment is done on time. So that is then the immediate settlement. But what you can also do, which we did in a quite a large scale pilot, is depending on the type of services that that individual would access. Let's take the example of a pregnant woman that is HIV positive, right? So she will come for multiple types of services. And of course, making the layers that absolutely treat the patient confidentiality, what you could do is bill all the HIV services to the Global Fund, right? So you have different payers, so you segregate the types of payments that are being done. And for her pregnancy journey, there's somebody else that pays for that entitlement. And that is done by this payment layer, basically, that facilitates all this. So that means that you can make this into something which can very equitable distribute the way of financing. So this is one example. Another example that I always like to take is the diagnostics for malaria, for instance. One of the other things that we have tried is to make sure that what we've seen is that a lot of people get treated often for malaria, but it's not always a positive diagnosis, right? So there's a lot of overtreatment, which can cause all sorts of side effects. So now by linking it to a wallet that you link to only a positive test, which is scanned through a mobile phone, that payment is released to the provider to pay for that malaria treatment. And so that is done then separately, and that could be built from funds that are dedicated there for malaria, without having them to put all siloed mechanisms of payment, which are there for very good reasons, because those donor funds and multilaterals, they were set up to treat those specific diseases. But what we are really looking for is to unite them in one platform, so that as an individual, I drive what I need, and in the back end, the payer is distributed, and now it is put on the forefront. So that is technology that enables it. And just to your question on the loans, yes, indeed, because a lot of payments still out of pocket, of course, but this is still the fact that are being done by people by mobile money is one of the things that we saw is, of course, those clinics that are providing those services, they have enormous challenges accessing financing. They get delays by paying the payment of the claims often, but also because it's postpaid, but in advance they need to pay and procure their medicines, pay their staff, etc. So what we have developed now is a cash advance product. We call it that way, and based on the previous 3 months average of the income of a clinic through mobile money, we are able to give them an advance for the next period, which is then automatically repaid by the individual mobile payments that are done during the day. So this is a very flexible loan that we can disburse within 24 hours, is uncollateralized, and therefore extremely helpful. And the biggest takeoff we have actually seen during COVID, because banks were not leaving their offices anymore. Everybody was in lockdown, but also those clinics were still serving some patients, but they were seeing less of them because people were worried and scared to move. But in the meantime, they had their costs. So we were able to do quite some cash advances and take a bit more risks, thanks to some guarantees from some development banks, indeed in the back, but very important. And we could still make sure that we could avoid foreclosures, unnecessary foreclosures, because of temporary disruption in the healthcare market.
Thank you very, very much for that. And that's going to lead me to a question that I'm going to ask for Erin, which is, you know, you work a lot with social insurance programs, so these national insurance programs. And one thing that Monique had mentioned was that these mobile wallets and digital financial services more broadly can cut those administrative costs, so that way we know that what we're spending on care is really going towards care, not towards the administration as much. Where do you see really these opportunities within universal health coverage systems to be able to use digital financial services that to make it easier for patients and also to support the UHC models themselves?
Thanks, Adrian. I wanted to check you meant me, not Anir, because our names are so close, but I'll assume that's for me. So, okay, I mean, in terms of the question on national insurance systems that are trying in our region to achieve high coverage, and we have quite a few contenders, you know, for that kind of title, looking at 80% plus coverage. I mean, so these are very large systems with very large data operations, information gathering, and processing needs. So across that, there's a fair amount of information systems refurbishment and upgradation already happening, but how much of that will become digitized and use some of the levers that we're talking about, which are, you know, fintech levers. I think here some interesting sort of trends that I see connecting to your question is that insurers are still using a lot of legacy systems that they inherited. And these are sort of amalgamation of your usual management information systems plus, you know, bespoke, you know, software systems that manage claims or are oriented towards the patient or the member. So there's not a lot of integration across these systems, and hence there's a lot of inefficiency and excess cost. So what we're looking to achieve in terms of what ADB wants is certainly to try and push our member countries and their insurance systems towards digital integration and incorporating some of the cloud-based and other technologies that we see, including machine learning, to try and automate and perhaps improve as many of these processes. So I'll give you a few examples. We want to see more member management, you know, really be on mobile phones, on platforms that people access, so people don't have to make journeys to an insurance, you know, outlet or a branch office. We want to see more more revenue collection be standardized and integrated back-end integrated with mobile wallets and other ways to pay, that are bricks to clicks. And we want to see the patients enjoying a very simplified and perhaps efficient online payment experience when it comes to routine payments such as premiums. Why doesn't that happen more often is a good question. I think there is still some risk avoidance or perceived risk avoidance among insurers that, oh, if we move to a digital system, will we be able to maintain proper records? And I think that kind of thinking will perhaps more or less start to go down. And on the provider side, I think we know that insurers will enjoy huge benefits from digitization. I think all the way from claim origination to fulfillment to fraud investigation. And we're seeing really interesting models even in middle income countries of using expert systems to automate fraud investigation, which is, as I think you would know, a very time consuming or used to be a time consuming process. So as much as insurers can recoup some of these efficiency gains and reduce their costs of doing business, they can pass on some of those gains back to their shareholders, back to even members in reduced premium costs and increased sustainability of the schemes themselves. And I'll end with this. Why doesn't this kind of reform, if it is such a slam dunk, why does it not happen more often? I think here there is a natural tendency for reform objectives or digitization initiatives to overreach, where the goals are extremely lofty and are set based on excellent use cases from elsewhere, but not a lot of contextualization of those use cases, those technologies back to the context of each scheme, each political system or political economy of that scheme. And I think making sure that we bite off what we can chew as an insurance program or as a UHC oriented scheme is very important. Some schemes may benefit from having a bespoke, custom designed solution. Others may benefit from using something off the shelf, and we have great open source management information systems and insurance software now coming online. So I think we'll see an interesting wave in the next few years of insurance systems in our region in the Asia Pacific going digital. Let's just hope they do it wisely.
Thank you. I think you've given us a lot of food for thought, and especially on that contextualization and localization of how important it is to bring in external partners from maybe outside the country when needed, or when it not necessarily when it needed, when it makes sense, but working with local partners as much as possible as well, because it fits into that context of both how people are using technology, how governance is happening, and also on just the digital journey within a country as well. And which leads me to Anir, is, based on some of the things that you've heard from Monique and also from Aaron as well, is, and also with the work that A2I is really leading around digital financial services, what are the opportunities that you see or the potential for FinTech for Health in Bangladesh that can really leverage some of the advancements in financial inclusion as well that's happening in Bangladesh?
Thanks, Adrian. So Monique's examples have been very educational for me, and also what Arun said brings very good perspective for Bangladesh. So in the white paper, I think we saw how the out-of-pocket expenses are very high in Bangladesh. It's 74%, which goes up to 84% if you're looking at medical tourism, mostly in India. So it's very high. If we look at how much money we spend on health, and if we can structure it better, so it's not just a matter of making the payments for my health services. It's really about new health products targeted to the underserved, to the poor, and new financial products. So that's where the nexus, the financial products and health products will actually meet. And technology makes it low cost. One thing that we say in Bangladesh is that digital Bangladesh is all about reducing TCV. So we've coined this term about 6-7 years ago, and it's become policy. Time, cost, and visit. So how much time have we reduced, how much cost have we reduced, and how many visits have we taken away? So we have done a calculation up until 2019. We were not able to do a full calculation in 2020. So up until 2019, we were able to save citizens about $8 billion. in reducing cost for them. Time, we've reduced about 2 billion work days, and visits, we've eliminated about 1 billion visits on around 100 services that we have tracked. So these are eGov services, not really health. I mean, health, we may use a TCV indicator, but maybe quality will also have to come in, because you don't want reduction of TCV and not high quality service for the poor. The things that we saw during COVID actually accelerated digital adoption. I mean, we saw telemedicine, which was promoted by private sector primarily for many years, did not really take off. During COVID, it did, because of obvious reasons. Doctors and patients did not want to meet in physical terms, but wanted to meet online. So phone and internet, so both were used quite extensively. We saw judiciary, another example, which we did not move for 5 years, become digital ready. So we were able to reduce overcrowding in prisons by 11% by introducing judiciary in 12 days. So these are examples of how the needle can be moved very, very quickly, even when there is huge logjam and huge resistance to change. So healthcare is at a point where digital health and digital finance for health, I think, we're at the tipping point, we're at the cusp of making this happen. So I see 3 approaches that would actually work well in the context of Bangladesh and perhaps in other countries. The first is looking at the current assets that we have and build an ecosystem around it. So what is the digital financial ecosystem that we have? What is the ID system that we have? What is the data system that we have? So, and then building around that. So instead of building from scratch, we actually repurpose what we have. I think that's the approach that we have taken in Bangladesh. Second is doing a lot of experimentation. And what Monique talked about, I think we can learn from that and just try things out. So instead of over-regulating, I think we should just try things out in sandboxes of health, sandboxes of fintech. And that's what we have done with the fintech work that we did in the last 4 or 5 years in Bangladesh. So sandboxing it, reduce risk, do it in a risk, I guess, calculated environment, and do a lot of experimentation on different types of products. So insurance does not have a great name in Bangladesh. So whether we should really start with InsurTech, we have explored it recently, but perhaps savings and credit are good instruments to start with, because it's, you know what you're getting. Insurance has a bad, people feel that they never get better. It's also a complex part. So I think looking at simpler savings and credit would be useful. Building within our social safety net program some kind of a health support, because it's such a large budget, I think would be helpful. We are now looking at telco data for poverty ranking. So this is a fairly cutting edge approach that we have seen in Togo recently, and we're exploring whether to test this out in Bangladesh, and we will start the work with a couple of different organizations very soon. So looking at telco behavior of citizens, consumers, and then see if we can do poverty ranking. So all these kinds of information will give us a lot of experimentation. The third thing is we need to have data sharing agreements. So because what we're talking about is really a collaborative effort of multiple agencies within the government. So the Ministry of Health alone cannot do this. Bangladesh Bank, the central bank, cannot do this alone. Finance division cannot do this alone. So it's a combination of different organizations and supported by technology. So ICT division cannot do this alone as well. So we have to bring in all these different public agencies and get our data sharing agreements across them. And also with private sector. So the syndromic surveillance that I talked about, using a lot of private sector data, using data from private hospitals and data from telco. And this data is usually not shared with government typically, but we created again a sandbox where data sharing was possible with private sector in an anonymized way, and we were able to come up with this system within a month or so. These are all examples where 3 things I mentioned in terms of building ecosystem by repurposing current assets, doing a lot of experimentation, and then data sharing will actually allow us to understand what works and what doesn't, and then we scale up from that standpoint. One thing that I would also like to mention, two more things actually, in the interest of time, I'll be very quick, is the blended models. We're not really talking about fintech for health in just the digital space. The blended model, and we have in Bangladesh those 6,000 digital centers that are the bridge between analog and digital, as I talked about. We have 14,000 community clinics. We have government health workers, about 60,000 plus or so, 50,000 BRAC health workers. So they go from door to door and they have a lot of information about what's happening in the health lives of the rural people. Urban is a different story, and we will have to look at urban slightly differently, perhaps. But what we have assets in terms of data coming in terms of human touch, we need to blend that in. It's not just a digital ecosystem that we look at, but the digital and the analog, the brick and mortar and the click and mortar type of thing that I think Arun talked about. The last thing I'll also mention is we have funded from an iLab initiative. It's called Innovation Lab within A2I. Funded a number of low-cost diagnostic devices. So if we can actually introduce low-cost diagnostics, and what we are exploring right now is with our Ma Telehealth Center, which is the telehealth center focused on women's health, pregnant women and lactating mothers. If we can actually have very low-cost devices that will give us near real-time data or perhaps real-time data, that reduces risk and that reduces cost of service delivery as well. But again, we have to look at different types of experimentation with devices, fund these devices in the country, perhaps import a few, but we have to develop these devices within the country also. So all this have to come together and then make sense to develop the right fintech products and right health products to make F4H happen. Thank you.
Thank you for those examples, and especially really with that focus of saying, you know, the assets that are already there in Bangladesh, you know, and honestly, I think one of the biggest assets is also just A2I. I talk about A2I quite a bit with our work with other countries as well, and just the fact that there is this arm of the government that is coordinating across sectors, knowing that solving these really big challenges does take a cross-sectoral approach. And of course, you use the magic word of sandbox that, you know, I think a number of people on this know that ultimately what I want to see is, you know, fintech for health sandboxes of saying, how do you put these regulatory parameters around this experimentation that can happen between two highly regulated sectors to solve these challenges. So thank you for those comments. And I now have a question for Dr. Mo, which is that, you know, you're the chief executive editor of a series of publications or reports, including the report of financial inclusion in China. And, you know, through the research that you've done, can you share some of the examples that you're seeing where fintech is being used in healthcare, and how this could translate into opportunities that other countries could learn from as well?
Okay, thank you. I actually not working not focused on fintech for health, but we did do some have some example or something I think about this before. As you know, the fintech grows very fast in the last few years in China, and also the healthcare industries also benefit from that. It's in a couple of ways. The first, I think it made people's access to the financial support, especially the credit loans, very easily. As you know, Alipay and also Tencent Pays can access to a huge number of consumers, and they actually can make very quick borrows from these platforms, and also JD also another platform also. Usually, if people can pay in 1 or 3 minutes, it's very quickly. So if you need some money, so you just click on your mobile phones and immediately you can get an amount of money. So that can help the people who, when they are in sick or lack of money, they can borrow the money very quickly. I actually interviewed one small businessman last year during the COVID-19, and he told me that he actually borrowed 100,000 yuan from the platforms to help his fathers to get for his health care during that times. So that's the first thing, so you can get the monies. And the second, because how they get the monies, because the platforms use the big data to collect the big data, and they can able to evaluate your credit score, and then they can know how much you can borrow from that. So that's how they do their business. They basically based on their business data, and then to evaluate the customers, so that they can borrow, keep them a lending, make a lending very quickly. So the third step, now the government also thinking about that, or actually they already did that, use the government status to help the peoples to increase their credits, so that they can borrow monies and also borrow money for their health care. So that's make these business more efficiencies. And the things, fintechs, the fourth things fintechs can help the healthcare, that's help them to pay their pay for the doctors very easily. So and now they are in China, so basically in most area, or for most people, so we don't need to use cash anymore. Only some elders people, they will also still like to use cash, but most of the people, especially the young people, don't have money. We actually only use the mobile policy at this time. So this help the people when they insist they can pay their doctors very quickly, very easily. And the fifth, that's the international we call the micro healthcare, or you can like something like they have a program called V Doctor on the WeChat. So I can give you an example. So once I have a headache and at night, and I feel it's very bad. So I went to see a doctor, but I don't need to go to the hospitals. I just use my WeChat to connect to the doctors. Immediately, the doctor called back and to ask me what's the problems and give me the suggestions, the next steps, how I can take care of myself. So this is quite development now. People use the internet to get their health care. And the things I think it's also promotes some other insurance. Maybe you had heard about the Alibaba have a so-called mutual insurance or something like that. So you can people, if you try the programs and then if you get sick, you can get some paybacks about up to as I know, it's the highest one is up to 300,000 yuan for per cases. So that's for the if you have if sick seriously, so you have the source of payments. And the last ones, I think the health fintechs for the healthcare the results is that for the COVID-19 controls, as you know, so we are now all people in our mobiles have we call health code. When we go to a shop or a buildings or go travels through by trains or by air, we just scan and show our health codes, and then we can pass very quickly. So this makes our control the COVID-19 very effective. So if you have it's also in the codes also shows that your temperatures. It also shows that you whether or not you already test the virus, and also show that whether or not you have take the vaccines. So it's very convenient for us to show the people's so that the COVID can be controlled in effective ways. So I think it's generally there's some examples. There may be more others. So for time being, I will stop here and thank you.
Thank you for sharing those. And I think one thing that really highlights it is because I think China has been able to leapfrog other payment systems and really go from cash to digital payments. And this is one thing that we're learning is in the countries that are having this leapfrog moment, maybe they're having it a few years later than China has, but that's where it's easier to roll out these innovative financing models versus countries that are slower to adopt mobile payments. It really does become, it's something simple, but provides, again, that foundational, like Monique said, a foundational layer, and what we see as a foundational technology. So at this point around FinTech for Health, we really see payments as infrastructural at this point. They're required and are really needed in order to innovate. Shama, I want to go to you. I think you're really doing the most work on the ground right now with healthcare, and unfortunately we're down towards the end of our time. But I really want to hear what are the examples of where you see FinTech for Health really being able to support the work that you're doing at Swasti Foundation and with the people that you're working with.
Thank you, Adrian. I'm at the verge of what Monique was saying earlier, of literally spinning out a FinTech arm, because I think we're that desperate for innovation in terms of financing. And just picking up what Anir was saying earlier, it has to be about blended financing. It's just not going to be about insurance alone or payments alone. I think we're going to have to bring different kinds of financing to play. And I really see, and I, this is why I love these conversations that the FinTech team puts together. I think we're having to do those, experiments, sandboxing, and bringing it together. I just want to, put this idea out there for anybody who's still listening, and I'd love to work with anybody who want to do it. I think, we saw success with the whole self-help group models, the groups, right? But we know that in the urban context, that doesn't work. There's a whole physicality component to it. But we know that there is something about social groups, and how do we use that and bring that into FinTech and technology and the leveraging, those components, but bringing that online is something that just hasn't been done enough of, right? And I think while we're talking about payments and a lot of FinTech work today, at least in India, it's still about credit. But I do agree with Anir when he was saying that we do need to look at how we build financial security and resilience for people. And that is going to come from savings. It's going to come from expanding their income in ways which we use FinTech, but we haven't probably done before. For example, in India, just in the last 1 year, and without actually any FinTech, we've unlocked about 2,000 crores. This is roughly about I guess about $300 million US. This is just government allocations for schemes that have been enabled for people. We've just connected that, right? I mean, just imagine how much more unlocking. And I think this is what Arun was talking about earlier as well. But that just increases what income and what money is available in the hands of people. If we're increasing the financial incomes, we're increasing the security, health behaviors will change. And I do want to stress here that it's not about health behavior after they're sick, but how do we get people to do things differently so that they don't get sick? Because I think we talk about what happens once they're sick and then how we pay for their journeys, or we ignore or don't focus enough of what's getting people sick. I think nutrition was on your slides. I'm really grateful for that. I don't think we think enough about how people can access better nutrition. And really, honestly, good food is actually expensive in a lot of our countries. It's not right. So I think these pieces can get addressed if we bring in blended financing, we use tech and fintech differently and address it. And I agree with everyone who said we have to work across the different silos that we're in. It really has to work for people. And how do we do that? And I think that's where I'm at. We know that with cooperatives that we're working, that it is possible. We've seen that work. But these cooperatives are governance intensive. So how do we now move some of those models that have worked in the past for us, but bring in fintech to make it easier, lighter, scalable? And I think that is really the ask that I have. So thank you, Adrian. Back to you.
Thank you very much. And, we're wrapping up here. We're right on the dot for 9:30, which almost never happens with a panel that I moderate. I'm notorious for going over. So thank you, everyone. And I just wanted to say as well as when we talk about these innovations is, we want to invite people we want your feedback. We want your thoughts on this. If you're listening in or you're part of the panel discussion and say, I have comments, I have ideas, or here's some new projects that we'd really like to experiment with and see if this is something that people want and that they'll use. This is really an invitation of email us, call us, send a courier pigeon, whatever it takes, is we really are about this innovation. And so, just wrapping things up, Krishna, if you can just give a few words, and then we'll all be sending you the actual white paper at the end of this as well. The actual white paper. Yes, Krishna.
Thank you, Adrian, and hello, everyone. My role today is a bit like that flight steward thanking you for patronizing them, politely showing you where the exit door is and asking you to come back again. In the spirit and knowing that it has been 90 minutes that we've had your attention, I will keep it brief. I only have two things to say and conclude this. So I'll begin with quoting Yuval Noah Harari, who's the author of book Sapiens, which many of you might have read. So in his response to the question why humans dominate the earth, he said it's mainly two things, right, that set us apart. One is myth making, or how we create stories. And two is our ability to cooperate in extremely flexible ways with countless number of strangers, right? This pandemic is one example of how global cooperation is and why is essential, climate change or even healthcare, right? So we'll talk about the myth making some other time, but I'd like to emphasize on cooperation and partnerships. So as Will said, and the white paper is the first step for us in that direction. The Access Health team has put tremendous amount of work to create a strong and practical framework for enabling these partnerships between financial providers, technology providers, and healthcare providers, with an ultimate goal to design, test, and scale innovative solutions that improve healthcare affordability for millions of low-income people in Asia and hopefully beyond. So I'd like to keep a focus on that goal. And with all the progress that we've made around technology, the kind and range of partnerships that are possible today was not possible even 5 years ago. So I'm very excited. And in that spirit of cooperation and partnerships, I'd like to thank you for taking the time out to join us today on one more Zoom call. And more importantly, for your continued support. We look forward to working with you to strengthen our existing partnerships and build new ones with the ultimate goal of making a tangible and positive impact on the financial lives, health, and well-being of low-income communities and people who need it the most. Thank you, and I think you know where the exit button is. I look forward to seeing you again and staying in touch.
Thank you, Krishna. And if anyone's still, the white paper is in the chat. So for the attendees who are still on, the white paper is in the chat. You can take a look at that now. We'll also be sending it out to you via email as well. So thank you, everyone. Thank you for joining us today.
Very useful. Thank you.
Thank you.
Thank
Have a
you.
good day, everyone.
Thank you. Thank you.
Thank you.